Good evening, everyone. This is Batul from IJCP, and I would like to welcome all the viewers who have joined our platform for the better exchange of knowledge that is going to be shared on this particular platform by our panelists, by our renowned panelists who are here with us today. So, the topic for today's discussion is acute kidney injury in patients with liver disorder. And to have a discussion on this topic, we have our renowned moderator and speaker, who is none other than Dr. D.K. Sinha sir. Sir is senior consultant at the Department of Nephrology at Heritage Hospitals, Varanasi, Uttar Pradesh. So now we would like to introduce sir and welcome sir at our forum, and would like to hand over the stage to him for his precious talk to begin with the other panelists. So sir, over to you. Kindly please introduce the other panelists and
Thank you, ma'am. Thank you. Good evening, good afternoon to all the respected panelists. My senior Dr. Ratan Jha, Dr. Nagarjuna, and all people who are watching this live show. This is very important topic and assigned by IJCP, and I'm really feel privileged to be part of this live meeting. What we are going to discuss is basically acute kidney injury in patients with liver disorder. We all know that these two organs are very important organs of the human body. Their basic work is to maintain the homeostasis of different molecules and compounds. So disruption in one system usually affects many systems, but there is very close interrelation between these two organs, these two vital organs. Unfortunately, till date, there are a lot of hypotheses regarding why patients of liver problem develop kidney problem or kidney problem, sometimes even develop liver problem also. Primarily, they uh, try to maintain and manage the protein, carbs, and lipid metabolism. And at the same time, they are the main organs which basically manage the clearance of different pharmacological agents. What we are going to discuss kidney disease or AKI due to the liver problem. But at the same time, we would also like to see if there is some problem related to kidney in the liver. What is the very important that patients who are having liver and the kidney problem simultaneously, their morbidity and mortality is always very high, extremely high. So with this small introduction, I would like to introduce my two speakers. One is Dr. Nagarjuna sir. He is a very senior most chief consultant in Department of Gastroenterology at Sunshine Hospital, Hyderabad. So welcome, sir, in this show. The another speaker and renowned nephrologist of the country is Dr. Ratan Jha, sir, who is right now working as a uh, senior consultant at the Care Hospital, uh, Hyderabad. So to begin with, I would like to start with Dr. Ratan Jha, sir, that in your mind, what is the definition for the acute kidney injury?
Please speak in a bit loud voice because voice is not 100% clear.
Oh, sorry, sir. But could you get my question, sir?
Please repeat the question once.
Yeah, what is the definition for acute kidney injury?
Yes. This is a very basic question when we are going to discuss the topic that KDICO has given a kind of recommendation that all patients of AKI or acute kidney injury will be defined by two things. One is the rise of serum creatinine by 0.3 milligram per deciliter from the baseline and or a fall in the urine output which is sustained for more than 6 hours to the tune of 0.5 ml per kg per hour. So these two criteria has to be fulfilled to say that person is having an acute kidney injury.
So two factors are very important to make a definition of AKI. One is the rise in the serum creatinine. So one should have the baseline information of
Yes.
the serum creatinine. Even zero
Yes.
point 0.3 milligram rise is supposed to be fulfilling the definition of AKI. And another
Yes.
is decrease in the urine output.
Yes.
So coming to Dr. Nagarjuna sir, am I audible to you, sir?
Yeah, you're audible, Dr. Sinha.
Yeah, thank you, sir.
I can hear you.
Thank you, sir. Yeah, fine. Thank you, sir. So my question to you, when someone or any physician who is looking after his patient or her patient, how he or she will suspect that this patient is having some liver disorder? So I'm asking what is a vague symptom of, or what is
I
generalized
know.
symptom of liver disorder?
I know. I'm first. Let me apologize because I couldn't. Join the program through the proper channel. I could not postpone my trip, so I was in some other city. So since because I given that my word, so
Please, sir, go ahead. We are not getting your voice, sir. Dr. Nagarjuna, sir.
okay.
Yes, sir.
Yeah.
Not able to
Can
hear
you,
Able
you.
to,
can, can
able,
you, yeah, now it's
able to
okay.
hear me now? Yeah.
No, now it's okay.
Now
So
you're
Now
able
it's
to
okay.
hear.
yeah, good. I'm sorry. Thing is, when you talk about liver disease, usually this HRS happens mostly in the chronic liver disease category. Chronic liver disease, by definition, is the presence of fibrosis in the liver biopsy, or in the non-invasive category, when you have the F3, F4, that means patient had a chronic liver disease. Having said that, even acute liver disease also sometimes can cause kidney injury, like HRS kind of picture, particularly in case of alcoholic hepatitis. Alcoholic hepatitis can be an acute or even chronic. So, though we call it acute, alcoholic hepatitis maybe must be having something in the background to have a chronic liver disease. So, basically, what I'm trying to tell you is, we're talking about chronic liver disease. Symptoms usually are jaundice and ascites. Ascites is very important in the HRS category. So we are diagnosed mostly by jaundice and ascites. These two are important things. Other things may not be there depending on the liver disease severity. Maybe you can have liver failure signs, including bleeding, and sometimes there can be varicose bleed along with this background. So, so what I'm trying to say is, one is jaundice is an important symptom in most of the liver disease patients, and chronic liver disease, definitely ascites is an important thing to have this HRS. Yeah.
Thank you, sir. My next question to Dr. Ratan Jha, sir.
Yes.
So why some patients who are having liver disorder, they develop some kidney problem? So what are the way how this kidney can be involved in the hepatic disease?
Uh, so, kidney dysfunction in a patient of liver disease uh, uh, is quite common. It has been reported that patients who get admitted with liver disease and are evaluated in hospital, 50% of patients have an acute kidney injury, which is defined as the development of the kidney dysfunction based on the criteria that we talked about. Uh, it has been noted that roughly 50% of patients are having this dysfunction because of the volume deficient factor that is called volume responsive AKI, which is prerenal AKI. 20% of patients in the studies have been reported to have a true HRS, that is hepatorenal syndrome, which looks like a prerenal AKI but doesn't get better. And the remaining 30% are non-HRS AKI, that is, they are not related to the liver disease per se, but because of the associated conditions, they develop an acute kidney injury. So the percentage that we talked about is that roughly 50% of people will have a prerenal AKI, 15 to 20% have a kind of true HRS AKI, which may not get better with simple therapies, and remaining 30% of patients may have a non-HRS AKI, with very small percentage of people having a post-renal AKI where there's some kind of obstruction with a change in the creatinine output.
What I can get from your this statement, sir, ki, patients of liver dysfunction, who are having renal injury, can be with true HRS or maybe something else. Then we have to see
Yeah.
whether it is pre-renal or renal or post-renal. So
Yes.
not all patients who are having liver disorder and having some AKI is basically HRS. We have to
Yes.
differentiate between HRS true and HRS something else, means
Some
false or
some
something like
pseudo
that.
HRS. Yes.
Yeah, pseudo HRS. Great, sir. So another question to you. Again, I am continuing with you, Dr. Ratan Jha, sir. Why
Yes.
some patients of liver disorder and what are the mechanism? Means apart from what is the basically pathophysiology that in liver disorder some patients are prone to develop AKI or something like something
Yes.
similar.
The pathophysiological events which precedes AKI in patients of liver disease are basically two. One is the intravascular volume deficiency, that is relative intravascular volume deficiency because of many neurohormonal factors which produces a kind of vasodilatory state, and other associated events like translocation of bacteria which produces a lot of toxins which produces a kind of systemic vasodilatation, and a splanchnic vasodilatation which leads to reduction in the kind of blood pressure in the systemic circuit. So this basically is a kind of pre-renal kind of the impact on the kidney because of multiple factors, and kidney behaves as a pre-renal AKI with the urine indices which are akin to a pre-renal AKI. So it is basically a kind of low intravascular volume in the systemic circuit because of multiple factors, bacterial as well as neuroendocrine factors, and many other cytokines and chemokines which are associated with all these pathophysiology.
Great, sir. My next question to Dr. Nagarjuna, sir. How one can make a diagnosis of true hepatorenal syndrome in patients who are already having chronic liver disease?
Had Dr. Jha already mentioned, any increase in the serum creatinine, particularly more than 0.3 or up to 0.5 per day, usually indicates AKI. With the background of chronic liver disease, we usually try to make a diagnosis of HRS. Again, there are two types, type 1 and type 2. And type 1 has a high mortality, type 2 is a less mortality. But having said that, it's more of a almost the treatment appears to be almost similar in both the conditions. But in the type 2, you have to rule out a underlying renal disease. So to make a diagnosis of HRS, mostly it's a clinical diagnosis. A patient having a chronic liver disease with an increase in the serum creatinine and decrease in urine output. Basically, this is the thing.
Thank you, sir. My next question to Dr. Ratan Jha, sir. I think from very beginning, whenever we started doing our DM or so, it was said that in hepatorenal syndrome, most of the kidneys are perfectly normal from inside, and when somebody is doing a angiography, the everything will find normal, or even that HRS kidney is being transplanted in a CKD patient or ESRD patient, it will start working like that. Is the same concept is true right now also, or there is change in this concept?
Mhm. The basic concepts are similar. It is said that it's a functional the AKI in a patient of hepatorenal syndrome. So kidneys are usually not having an associated ATN, but in the late stages of severe HRS, one can develop an ATN where a patient can require dialysis support. So the diagnosis of HRS is basically a diagnosis of exclusion where you do not show any evidence of proteinuria, hematuria, and urinary indices are normal. That is suggesting that the kidneys are normal, etc. At least functional wise, etc. And histologically also we may find it to be normal. But the things can change from the so-called normal kidney to an ETN when there are many other factors get superimposed. So this distinction, though is theoretically valid, but may not be seen in patients who are having kind of HRS, which is acutely progressing and person has a lot of hemodynamic stress. So this is more of a theoretical kind of this thing, but it is said that patients who have HRS, who has been supported well and goes for liver transplant, they may not require any kind of kidney replacement because the kidneys are basically normal. So conceptually, it is a normal kidney, but it could suffer from a hemodynamic insult because of the associated problems in HRS.
I shall come once again back on this issue, sir, because sometimes people are discussing that many times these type of patients may require simultaneously liver and kidney transplant. But I shall discuss on this issue later on, sir.
Yes.
Right now, Dr. Nagarjuna sir is not online, so I shall
Yes.
continue with you. So
Actually,
histologically, you are telling the
can you
oh
can you hear me?
yeah, sure,
Dr.
sir.
Sinha,
Yeah, yeah,
Ratan,
yeah.
I'm sorry. I'm sorry to both the speakers. Yeah, I don't know why I'm suddenly logged out. Uh, thing is, coming to the point of, I think that Sinha, I doubt if in case of HRS type 1, we don't go for transplant of both organs. Generally, as Ratan just said, the kidney generally supposed to be okay, normal. So you go only for a liver transplant and usually cures the HRS also in type 1. Yeah. So, but problem type 2, I think what Sinha makes some point there. Maybe you have to go for transplant for both the organs. Generally, in HRS, it's mostly the liver transplant, which cures the condition. Till that time, till the patient goes for liver transplant, we have some drugs like, probably subsequently you'll be asking the questions about that for treatment of HRS. Yeah. Over to you, Dr.
Sir,
Sinha.
yeah.
Yeah.
Thank you, sir. Uh,
Thank you.
Sometimes people are talking that infective pathology also plays very important role, and something like translocation of bacteria is also very important in the gut, and that's leading to HRS. Is it true, sir? What is your take on this?
Yeah, it's true. Usually, most of the times, infection which triggers the whole mechanism of the HRS is only one of it. But as Dr. Ratnaj already said, it is more of vasodilatation, and which probably is multifactorial. But important thing is vasodilatation. Usually, the infection is a culprit in most of the case of HRS. Am I right, Dr.
Thank you, sir.
Ratanja?
Yes.
Yeah.
My I'm continuing with you, sir, because
Yes, sir.
unfortunately
Yes, sir.
you're losing
Yeah.
your voice in between. Uh,
I am sorry.
Sir,
I'm
what
really
is the
sorry.
difference between acute liver failure and chronic liver failure leading to HRS? Is there any change in the management part?
Sir, can you repeat the question, please?
Yeah, I'm asking, sir.
Uh-huh.
Some patients having acute liver failure and then developing HRS versus patients who is already having chronic liver disease and then developing HRS. Is there any difference in the management in these two subset of patients, sir?
Are you talking about acute and chronic liver disease, ACLF kind of thing?
Yeah. One is acute liver disease, one is acute and chronic liver disease, and then third one is the
Okay,
chronic. Yeah.
chronic liver disease. Yeah, so the difference in acute condition, there is no underlying liver disease as such. There is no chronic underlying liver disease. That means there is no fibrosis in acute liver disease or acute liver failure. And in case of ACLF is acute and chronic liver failure, where there is a fibrosis in the liver, that is a chronic liver disease. An acute insult triggering the whole thing, that is ACLF. And third one is chronic liver disease like cirrhosis. All of us know cirrhosis, fibrosis in the background, causing increased portal pressure and typical cirrhosis of liver. These three are the important things, sir. Generally, in HRS, we see most in the case of CLD, chronic liver disease. Having said that, HRS can occur even in acute condition also, rarely. It's not a common thing. But there is some confusion about the terminology, AKA or HRS, but that can also happen in case of acute liver failure. ACLF is more like CLD only, chronic liver disease only.
So
Yes, sir.
from management point of view, so do you feel there are differences in the management of
Uh,
HRS in different all these three subset of liver disorders?
by and large, there may not be many, sir, but the whatever experience we have is mostly for HRS in chronic liver disease, or maybe in KCLF also. We can say that. But acute liver failure, generally, I don't have many cases of HRS happening in that. Theoretically, yes, it can happen, but practically, I don't have much experience, and you see mostly AK in that. They don't meet the criteria of HRS as such. Dr. Ratanjay, can you elaborate on this? I mean, you are, Dr. Sinha, one of you can highlight this point.
The renal injury in a patient of acute liver failure probably will be more behave like a AKI, ATN like presentation much more because they are hemodynamically much more critically ill, etc. So there
Yes.
the treatment will be probably to support the liver and maybe dialysis may be required. But HRS developing in the context of acute liver failure, though it is mentioned, I have also no personal experience of labeling a patient of HRS in a patient of acute liver disease. Most of the time it is labeled in the context of acute and chronic liver failure or in case of chronic liver disease decompensated.
Agree. Exactly. My opinion also same. Exactly same.
Thank you, sir.
Thank you.
Dr. Nagarjuna, sir.
Yes,
So there are
please.
different causes of chronic liver disease. So what are
Mm-hmm.
types of chronic liver disease are more prone to have HRS? There are few conditions in which even patient is having liver failure, but most of the time they do not develop HRS. Is it there any difference between types of liver disorders?
I don't think so, sir. My opinion is anybody having a chronic liver disease, irrespective of the etiology, the HRS is almost similar kind of incidents. In this case, leave out the alcoholic hepatitis. Alcoholic hepatitis is different condition altogether. Alcoholic hepatitis is more of a acute liver injury over a underlying chronic liver disease kind of thing. But coming to the other etiology of CLD, that is chronic liver disease, the hepatitis B, hepatitis C, anything, by and large, they have similar kind of presentation and similar chance of developing a HRS. There's nothing much to choose, as far as I know.
Thank you, sir. Thank you.
Thank you.
Dr.
Yeah.
Jha, sir. Uh,
Yes.
so usually we have read many classification of AKI like rifle, Akin, or Predigo. Which should be more practical in the clinical practice? What is your take on this? So there are different, a lot of confusion between different classifications.
No, the difference between the Akin classification of AKI and KDIGO is just bit of semantics, etc. Because Akin considers AKI as till 48 hours if creatinine has a zero point 0.3, while the KDIGO extends that kind of thing to 7 days. So practically speaking, they are same. We go by KDIGO classification because that is the nephrological way to look at it, etc.
Thank
Okay.
you, sir.
I'm thankful that I'm not a nephrologist. I'm happy that I'm a gastroenterologist. For both of you, I think your life is miserable to finalize what is AKA type 1, type 2, type 3, or maybe stage 1, stage 2, stage 3. And there's so much of confusion about the
Another
terminology. It keeps on changing over the years.
No,
my another question to
Yeah.
Dr. Ratan Jha, sir.
yes.
So if you are
Mm-hmm.
going to explain the pathophysiology, I think this question for both of you one by one. If you are
Mm-hmm.
going to explain the whole pathophysiology of HRS, what is your take? Can you tell me the step by that the patient how develops the HRS? What's happening first, then first? Because a lot of confusion on this issue. Including this confusion is also very evident even in the treatment part also. So
Yes.
sometimes we are using vasoconstrictor, sometimes we are using vasodilator. So there are a lot of confusion. So just for the sake of clearance for all the audience and for myself also, can you both of you one by one explain the pathophysiology of HRS?
the the HRS in simplistic sense is a kind of the hypovolemia continuing with the kidney suffering from a pre-renal state. So before we say that it is a true HRS impact, we need to exclude the true hypovolemia, that is volume depletion, which is quite common in a patient of chronic liver disease because of diarrhea, because we are giving laxatives, diuretics for treating ascites, many times GI bleed, and many times infection which gets added to that, which produces a kind of hypotension kind of thing. So which all of them ultimately are the pre-renal factors. So whenever we see a patient of cirrhosis of liver or liver disease with AKI-like situation, first thing is we send the urine sample, look at the urea and creatinine, look at the blood pressure, and clinically examine is there any evidence of hypovolemia. That means patient has no edema, blood pressure is low, tongue are dry, which may not be very, very sensitive marker, but that is the only clinical marker. And if we have access to a kind of this ultrasound, we look at even the inferior vena cava diameter, a chest X-ray to see whether is there any fluid overload, to be sure that whether to give fluid or not. So if we are clinically thinking that person has lost fluid, we first give a crystalloid. If there is no clear-cut sign of fluid loss, but patient's BP is on the lower borderline size, we stop diuretics and give an IV albumin and see the change in the creatinine in 24 to 48 hours. Decide whether we have treated the hypovolemia part correctly or not. If the hypovolemia is the factor, it will definitely show a response in the form of change in the creatinine, which is towards the normal side, that is fall of creatinine of 1.3. But if it is not falling, and urine is still showing a feature of pre-renal state, that is decided by a fractional excretion of sodium if person is not on diuretics, or fractional excretion of urea, which is said to be very, very important marker, which is if it is less than 21% in pre-renal state. These are said to be a helpful indices in a select situation to decide whether to continue in the form of HRS, or this patient is already a non-HRS AKI, where patient may require treatment on the other line, that is dialytic support or some other kind of therapy that is there. So first thing in any patient where we're seeing a patient with AKI is to exclude that the pre-renal factor by giving either a crystalloid, which will be in the form of normal saline or half strength normal saline depending on the sodium level, or give albumin to correct the volume status and see in 24 to 48 hours what is the track record, that is the creatinine changing or not. If creatinine is not changing, then there is a possibility of true HRS.
What is your take on this pathophysiology of HRS, sir, Dr. Nagarjuna, sir?
Yeah, it's almost similar lines. One is in chronic liver disease, by and large, patients will be having a low blood pressure generally. And on top of that, when you use diuretics, yes, they tend to get some hypovolemia. Apart from this, most of these patients, somehow they have a hypovolemia peculiar, mostly to the kidney. So in the rest of the body, the blood pressure can be fine, but for the kidney, this one, there can be relative hypovolemia. One thing is maybe the vasodilatation, which is occurring there and causing the hypovolemia kind of thing with subsequent kidney injury or kidney symptoms. I completely agree with Dr. Ratanja and try to correct the hypovolemia either by crystalloids or the best is albumin in this condition. They don't improve in certain period, in certain time, like in 24 to 48 hours. I think you need to think seriously about HRS. Now, with the advent of a new drug, the particular telepresent, the results are really good. So, I think the early identification of the HRS is very important. So, pathophysiology-wise, relative hypovolemia with vasodilatation. So, this is my take on this for your question, sir.
Thank you, sir. I'm continuing with you, Dr. Nagarjuna, sir.
Sir.
What are the other organs which are also involved during the HRS apart from kidney? Because is it possible that other organs also involved at the same time, which may be contributing in the worsening of the HRS?
Generally, sir, the infection which triggers all these things, that is fine. But HRS per se, the other organs may not get involved that much. But having said that, in a case of chronic liver disease, if you have something else in the like alcoholic etiology, alcoholic what is that cardiomyopathy, all this is separate, sir. But there's no relation between the HRS and the comorbid conditions of the other organs. So this is my opinion on your question, sir. But in
Thank
a
you,
given
sir.
patient, he can have a lot of other problems alongside. Yeah.
Yeah, thank you, sir. So my next question to Dr. Ratanja, sir. See, you know that the patients who are having chronic liver disease, they are already emaciated, they are having a low muscle mass. So in this and large volume edematous patient, in this condition, how it is possible to make a proper diagnosis of how we can define the true value of serum creatinine in the terms of GFR. So what is your opinion on this, sir?
That's
We
very
are
GFR.
important.
Yes, we are aware of the limitations of serum creatinine because sarcopenia is a common problem, and this being a problem even in the ladies as well as the older people where the CLD can present in that kind of condition. We have to know that this may give you will underestimate the GFR. It has said that we use the GFR equation which is available. That is the CKD EPI equation 2021. The recent equation where the race is not included, to have a rough calculation of GFR, knowing fully well that it will underestimate the overestimate the GFR by 10 to 20 ml. So if suppose you are getting a GFR of 40 ml by that formula, that means that GFR may be still 30 ml in true sense. That is what is reported in literature. One of the methods which has been suggested is to have a 24-hour urine creatinine for urine collection for creatinine clearance, but that is a very cumbersome method and is not practically used, though it is talked about in literature. So for all practical purpose, we need to have a clinical judgment, etc. We check with the formula. We know that it is overestimating and look at the trend rather than to go by one record to decide what is the GFR.
Yeah,
Serum
the most.
creatinine. Yeah, sir. Please go ahead.
Yeah, Dr. Ratan, please go on. I thought you finished. Yeah, go on, sir.
No, Dr.
Ratanji.
Nagarjuna, you add from your side.
No, Ratanji, I think he is supposed to complete something more. He's trying to say that. Unfortunately, I interrupted in between. Ratanji, please continue.
No, but I have said that the creatinine is not a very reliable marker, but we have no good marker at the moment which is recommended. 24 hour collection is also said to be one of the things to add on. Try to look at different things to come to a conclusion based on a clinical judgment and the trend, because do not go by one.
Yes. So my take on this condition is that's what the new definition. I mean, the definition which evolved is that the increase in the creatinine is important thing to make a diagnosis of HRS. We're really not bothered about the baseline creatinine. But the jump in the creatinine, that is very useful, and low urine output. This is my take on your question, sir.
Yes, so for all the audience, the most important aspect of this discussion is that in the patients who are having a hepatic problem, they are usually having low muscle mass, large volume of distribution because most of the time they are edematous. Sometimes the raised bilirubin also interfere with the estimation of true serum creatinine. There is also increased tubular excretion of the creatinine. So that also gives a false value of serum creatinine. So basically, serum creatinine evaluation is more for a stable kidney function, not for a AKI patient. But because we don't have any specific other markers, so we are relying on this marker. Is it? So at the same time, I'm asking Dr. Ratan Jha sir, do you feel there is any role of different biomarkers that is being used for AKI?
For all practical purposes in India, there are no biomarkers available for use, though this nephrocheck was a biomarker where the two kind of these biomarkers were utilized, TIMP2 as well as insulin growth factor binding protein 7, which was said to be a good biomarker to make a diagnosis of pre-renal versus renal, but it is not freely available. Other biomarkers which have been used in the cardiac setting, we have never utilized that. And we have in our clinical experience, the only biomarker we have used is furosemide stress test. If person responds after the fluid hydration, that means person's kidney is normal. That is the usual thing that we do in non-hepatorenal setting. So biomarkers are there, but not been very useful in our clinical setting, because by the time we get the report, the decision has to be taken.
So right now, whatever biomarkers available with us, it's not going to be useful clinically for these settings, including NGAL, KIM, interleukin, and all that. Okay, fine. Thank you. So now I'm coming to Dr. Nagarjuna, sir. How we can prevent incidence of HRS in our patient? What we should say to our colleagues or our residents or to the patient, what one should avoid to avoid the precipitants of this HRS? Are you getting, sir, Dr. Nagarjuna?
He's muted.
No, but he can hear. How we can prevent?
You. Yeah, got your point. Your question is loud and clear, sir. Am I audible to you?
Yes, sir. Yes.
Yeah. So thing is, one is they avoid indiscriminate use of diuretics. So that is one. Second is avoid NSAIDs, painkillers. Should not in this kind of situation. to prevent the HRS, important thing is avoid NSAIDs, non-steroidal inflammatory drugs. That's very important. And the third one is avoid infection, because infection is one of the most important reasons to develop in the development of HRS. So avoid the infections. And fourth one is avoid hypovolemia. So anything is there, immediately try to correct the hypovolemia at the earliest. These four are important, sir.
Thank you, sir. Thank you.
Yeah.
Now coming to Dr. Ratanjha, sir. Uh, See, as we discussed that basically diagnosis of HRS is a clinical diagnosis. Uh, but apart from that, there is any other specific, though we are not using in the clinical practice, do you feel there is other possible investigation in our patient to make a diagnosis of HRS?
Uh, so, HRS that we all know is a diagnosis, exclusion, etc. That where you are demonstrated by the ultrasound, the kidney size are normal. By urine examination, there is no proteinuria in general, and no hematuria, absence of shock, and an absence of any other drugs which have been just given preceding that, which can cause renal failure. So this is basically a diagnostic criteria to say that these are not there, then possibly this could be an HRS. Uh, but HRS as a cause for AKI in a patient with liver disease is the least common. The commonest thing is the renal kind of AKI which is there, and maybe a renal AKI, that is a ATL-like AKI because of other factors like because of infection or hypotension because of any reason they develop ATN is much more common than the prerenal than the HRS. So we should always look at the reversible causes of AKI before we say that HRS is there, because it is a virtual death sentence for most of the patients, because many people cannot get a renal transplant.
So just for theoretical point of view, I'm just asking this question. I'm just going through some literature and then got one very specific uh, terminology that uh, contrast ultrasonography. Is it something like that which can be used for this purpose?
Because I think probably you will be able to give the answer, because have you never used it? Because such a serious situation, then these kind of imaging are not done, etc. Because we are always struggling with managing the life at that point of time. So we have not done contrast this ultrasound in any of our patients. I am not fully aware because they are not read this thing whether
I've
that
just
can
I've
help
just
in
just
this.
going through the literature. I saw it, sir. Thank you, sir. Thank you. So
Yeah.
making a rapid diagnosis of HRS is very important because we have to point out the precipitating cause. Then we have to treat accordingly. We have to maintain the volume, and we have to give albumin and all those things. Now coming to the management part, sir. Uh, my question is to Dr. Nagarjuna, sir. What is the
Yes, sir.
broad management of HRS?
The broad management HRS, there was many were tried, but the best at this point of time, the best treatment is telepressin 1 gram, 6th hourly or 8th hourly, along with albumin, about 100 grams per day. That is uh, like twice a day, usually that's enough. So IV albumin plus telepressin is the answer, sir, at this point of time. The best
Then,
possible
sir,
treatment.
yeah, but just other like use of octride and use of midodrine, albumin, noradrenaline. So what is your
Yes,
take? Because there are some combinations also are being.
yes.
So how we can decide which patient is suitable for which protocol of therapy?
So the other protocols like norepinephrine along with albumin was tried, and people also added octreotide for that, and nothing great about it. Midodrine to prevent the thing is useful in the follow-up, not as a first-line treatment. So at this point of time, the best results are only with the albumin plus telepressin, sir. And you can try these things. Suppose patient had a hypotension, norepinephrine you can give, and so even they give dopamine also, low dose dopamine. But they're not that. At this point of time, they're not the best possible treatment regime, sir.
So Dr.
Hello?
Ratanja, sir,
Yeah.
Yes.
yeah, uh, some people are now talking the use of midodrine also in this situation. What is your take on this, sir? use of midodrine.
As per
That's a question.
the guidelines, midodrine is not a drug to be preferred, but in case the other drugs are not affordable, one can use it in a bit of a chronic situation. In an acute situation, this is a drug which is not recommended. We have seen our gastroenterologists prescribing this in a chronic kind of HRS, that is type 2 type of HRS, with good symptomatic kind of stabilization that is there. But for acute situation, it is a drug which is not recommended. You have to use either terlipressin or low dose kind of norepinephrine along with albumin. That is the recommendation that is there.
So normal management for if we are talking of normal management is basically vasopressor, that is the terlipressin and then albumin.
Yes.
Yes.
Okay, fine, sir. So where this tips basically stand in the management overall management of hepatorenal syndrome? Is there any role of tips, sir?
In one word, there's no role, sir. In one
So
word, there's no role. People
who
they
are the
tried.
patients in which may be useful? Yes, sir.
People tried, sir, but there's no meaningful improvement with the tips. So it's not a recommended treatment for HRS.
Great, sir. So tips is looking at so fascinating word, but this is
Yeah, I
not a
know.
modality of treatment in the patients who are having HRS.
Not in
Now,
HRS.
thank you, sir. So my next question to Dr. Ratan Jha, sir. You know that many patients, in spite of our best effort, develop acute kidney injury and many times may require renal replacement therapy. So how we are going to proceed in such type of patient? Which modality of RRT would be more suitable, or you may get a better outcome?
Uh, the this area has not been properly addressed in the literature. This is said that one has to decide on an individual basis based on the team approach as well as the patient's attendance expectation. The clear-cut indication for giving the renal replacement therapy are the classical findings like hyperkalemia, fluid overload, or a suspicion of possible reversal of the acute factors. That is the thing where you have to support the life till person stabilizes. So, but with the risk involved of every procedure that is there. So, renal replacement therapy is to be done only when we are suspecting a non-HRS AKI or person has a kind of hyperkalemia or volume overload, which is making the treatment difficult. It's a refractory situation. It is a individual option. Many times this doesn't work out. We do it, but it doesn't work out. So renal replacement therapy is not the thing which is recommended. And in general, if there are no transports, no liver transplant options available for patient of HRS. But when an option is available, we try to support with both hemodialysis as well as special dialysis that we call albumin dialysis, which are different names are there for that support that can be offered wherever the facilities are available.
So what is the difference between the intermittent renal replacement therapy versus the continuous renal replacement therapy?
This question is to whom? Nagarjuna? Me?
No, my question is to Dr.
Sir, I
Ratan
am
Jha.
there. I am there. Jai is supposed to answer that question.
Yeah, I'm asking the difference between outcome, the difference in the outcome from the IRRT versus the CRRT.
The outcome, there are varied literature, etc. People have opted different kind of renal replacement therapy based on the availability of those resources, etc. Outcome is not much influenced by any of these interventions.
So my next question to Dr. Nagarjuna sir, is there any role of extracorporeal liver support?
Sir, again, people tried, but nothing much. There's no great benefit, sir. The only definite treatment is liver transplant. Short of it, temporary measure, this telepressin and albumin, sir.
So where all these modality like Mars and this Prometheus stand right now?
No, no. Right now, there's not much use, sir.
So who are the patients in which this extracorporeal liver support may be beneficial?
At this point of time, sir, those who are using once a while, but there's no, I mean, to bridge it for the transplant, but somehow our results are not encouraging. So maybe in few centers they're getting good results, but generally, what experience we had with some of these Mars equipment, nothing much great, sir. And we used only in case of maybe in case of ACLF kind of thing, but again, the literature is not supporting that much.
Thank you, sir.
Thank you.
And I am continuing with you. Who are the patients who are in which we can plan to go for a liver transplant in patients or the chronic liver disease as well as the patients who are having the HRS? So how we
Uh,
can make, yeah.
so the liver transplant, the criteria is similar, same, sir. That is, you have to go for by MELD criteria. Obviously, with raised creatinine, the MELD score automatically increases. So they get the priority in the allocation of liver transplant. That is one. And the HRS as such, I mean, massage because of raised creatinine, because of what I'm saying is, yeah, raised creatinine along with the raise in the MELD score, they become the candidates for liver transplant, sir. Yeah, I'm sorry, I was traveling, so that's why I was missing few things. Yeah.
No, sir. Thank you, sir. Uh, Next
Yeah.
question to Dr.
Thank you, sir.
Ratanjha, sir. Is there any role of bio-artificial support device which can we have the combination of that means uh, normal dialysis along with some hepatic cells are being used for their inner lining and then you can get something out of that. So, do you have any idea or do you have any
Uh,
take on this
the,
bio-artificial support devices for the liver failure patients?
these are all maybe research kind of the reports which are there, etc. I'm not aware of such kind of therapy. I was told that at some centers in Hyderabad they are doing such this kind of research, etc. But I have no personal experience, and probably in the literature also these kind of things are not being discussed. Means at the moment this is in infancy. This is basically a kind of tool which is people are trying to explore, but there's no kind of meaningful results out of that.
Dr. Nagarjuna,
I
sir,
agree with Dr. Tanja. Yeah, yeah. Go on, sir.
so what is your take on this issue?
The same,
Bio-artificial support
what
devices.
Dr. Tanja said holds good. Is all in the research settings we are doing it, and we did some cases, but there's no benefit, sir, at this point of time. In future, if they have a better quality things come up, maybe, but still it's in the infancy only. And I think there's one more. I forgot the name of that. Our nephrologists used to use it in the COVID case, COVID time. Adsorbent, adsorbent. Cytosol.
Cytosol, sir.
Cytosol is the trade name. Yeah, cytosol. We had some experience with that also, but not in HRS and CLD, sir. But during COVID time, we used to try that. But I don't think they're useful in our setting of HRS and CLD.
It is more of a theoretical point right now. So there is
Yes.
no
Yes.
clinical benefit right now, and it's not being used in the clinical practice as well. So
Yes.
now coming to the
I just want to
patient,
add one more point, sir. Yeah,
yeah,
sir, sorry, I'm interrupting, sir. I want add one more point. Yeah, just one point about the HRS and CLD is the people who get the treatment, usually the response is good and they recover. But there is a chance for recurrence again. We had some patients who get the recurrence of HRS, well treated patients who respond very well. The take home message is the same combination works very well for them. Same albumin and telepressin. Yeah. I just want to share this point, sir.
thank you, sir. Now,
Thank you.
some of the patients are going for renal transplant. So even after, sorry, liver transplant. So even after liver transplant, some patients may develop acute kidney injury. So Dr. Jha and Dr. Nagarjuna, sir, can you both tell which subset of patients are prone to develop AKI even post liver transplant, and how we can prevent
Before,
the, yeah.
yeah. So before that, Ratanjak as a response, my my response is, I don't have much experience in this. Though I had some cases in KIMS when I was in KIMS, we did these cases, but my experience is limited, sir. So maybe Ratanjak can give us more information about this.
Uh,
Sure.
Though I have few patients where I have seen that liver transplant followed by kidney failure, where kidney transplant was done, it was basically attributed to the CNI. So the patient have followed 20 years follow-up liver transplant. So CNI is a drug which can produce nephrotoxicity in the follow-up, and people can develop it because of drug. But there are many patients who are diabetic or who are having steatohepatitis with liver disease, with background diabetic kidney disease. In the follow-up, they can develop this problem because of diabetic kidney disease. So the causes of renal failure which will require transplant for kidney could be because of the basic disease, or could be because of drugs, or some unrelated problems which could be seen as is seen in any other patient. So we have to have all kinds of differential diagnosis of kidney disease which require transplant even in post-transplant cessation and liver disease. But tacrolimus is one of the drugs which is commonly prescribed for taking care of liver transplant, which has led to at least kidney injury requiring kidney transplant in two of the patients that I have followed in last 30 years.
So
So
if you are going to,
Yes.
sorry.
sir, please go ahead.
Sorry. Okay. Now, Dr. Sinha, what he's asking is, Dr. Ratanja, what he's
Yes.
asking is, in following liver transplant following liver transplant, how many of the patients are getting this AKI? Maybe HRS. I don't. That's what he's trying. I think that his question was.
Yeah, I
Following
was
liver
asking you. Yes.
following liver transplant, HRS should not happen, etc. Unless the liver.
Then AKI, I'm asking the AKI.
But AKI, at least all things are possible, etc. I do not have any kind of personal experience of long nature, etc. We have seen at least two patients with CNI toxicity, documented CNI toxicity based on the histology of kidney failure. But other causes are also operative in all the patients, like diabetes, hypertension, maybe there in such patients, which can lead to kidney failure in the follow-up. By transplant per se, it may not lead to renal failure in most of the situations.
So Dr. Ratanjha, do you feel that the combination of immunosuppressive drugs that are being used post liver transplant, they are very important, and what are the drugs which are being preferred drugs, or including the induction and then maintenance of the patients? So which drugs usually is being preferred by the transplant physicians in liver transplantation?
But I have never been associated with any patient where the liver transplant was done and I was asked to see. So maybe Dr. Nagarjun can say, but in our center now in care, the liver transplant is done, but I have never been called to see any of such patients. So I don't know what do they use, but usually that they use is low dose steroid along with tacrolimus, and maybe other drugs are also used. I have no idea about it.
Dr. Nagarjuna sir?
Yeah. So I had some experience when I was in the main KIMS. So in my center right now, we're not having much transplant program. So my experience now is limited about this condition. That's what I said before we start the discussion.
Thank you, sir. So we had a very elaborate and very fruitful discussion on this very important topic. So we have already crossed, or we are close to our limit of time. So at the end, I would like to have a take from both of you one by one regarding the overall management of acute kidney injury in patients who are having liver disease. Dr. Jha first, and then followed by Dr. Nagarjuna sir.
Uh, well, the problem of AKI with liver disease is quite common. We must look at the urine examination, which is the least focused test in most of the patient who develops kidney injury with liver disease, because that is the last test to come. That can give a very important clue if you are looking at the fraction excretion of sodium and a fraction excretion of urea to decide that it is a true HRS or a renal state, or a patient has already established ETL. Treat the hypovolemia, look at the vasoconstrictors, prevent the kind of infections with appropriate kind of antibiotics which are given, and refer to the right center where these things are looked after more closely, because this requires a team to take care of such patients.
Thank you, sir. Dr. Nagarjuna sir. your take on this very important topic?
Yeah,
Dr.
hello.
Nagarjuna? Yeah. Your take on this very important topic.
Hello.
Yeah, please go ahead.
The audio is not very clear because I'm traveling, sir. But I
No
mean,
issue.
I could hear Dr. Ratanja's comments. It's almost same,
Yeah.
sir. Yeah, first, most important thing is, in a case of chronic liver disease, my important take-home message to the audience is, don't use diabetes indiscriminately. Very important. And always keep a check on the creatinine and urine output. And whenever you have any slightest doubt, step back, stop the diuretic, and consult the nephrologist or gastroenterologist. So I'm sure definitely we can save a patient. One. And second thing is, in this kind of patients, never use the painkillers just like that. NSAIDs particularly, you have to give, but with a pinch of caution, a pinch of salt. You have to explain to them and make sure they follow up with you properly. The third one is the infections. The infections are very important. If somebody gets infected, immediately look for all the parameters and treat it aggressively. Then fourth is hypovolemia. So whatever the reason may be, make sure you replace the fluid as well as possible. In this, crystals are better. Yeah, sorry, colloids are better. Albumin is a better choice to replace the fluids. I mean, when you suspect a hypovolemia. This is my closing comments about the HRS and chronic liver disease.
Thank you, sir. And in this colloid, I think albumin is supposed to the best one. Is it so, sir?
Yes, sir. Yes.
Thank you. So thank
If
you
they can
both of
afford.
both these
If,
speakers. They have answered all of my questions. In fact, I was so curious to listen both of you because I got a lot of things from both of you. Though I read something for this very important, but what I got really tremendous. I'm thankful to IJCP for giving me this opportunity and hopeful this discussion may be useful for many of our physician friends, the coordinator. Thank you.
thank you.
Thank you.